All right, good evening, everyone. I just wanted to welcome all of you to this year's Nebraska Oncology Society Evening Speaker Series. Now, before COVID, the Nebraska Oncology Society would meet pretty regularly to discuss different topics in oncology. Unfortunately, last year we weren't able to do that as much. So this year we've been able to pivot to a virtual setting until we are able to meet in person again. And our first topic for the year is lung cancer. Now, with this format, I just wanted to go over a few housekeeping items. First, we are using the regular Zoom platform. So you can find all of your webinar controls by hovering over the lower section of the Zoom screen. You can find your microphone, webcam, and chat box options, among other things. And I'll just ask that you please make sure to keep your microphones muted throughout the meeting. If you need to ask questions while the speaker is talking, please use the chat box. And then we'll have a Q&A session after each talk. So you'll be able to unmute yourself and ask your question. We'll address all questions at the end of each presentation. And feel free to use the chat function to send messages privately to individual attendees if you'd like to do that as well. If you have any technical difficulties, please close your browser and use the link to access the webinar once more. Otherwise, feel free to either send me a message or an email, and I'll hopefully be able to help you. We are encouraging the use of webcams if you're able to, in order to help just keep that more of that face-to-face atmosphere throughout the meeting. And I also want to remind you to please go ahead and visit our exhibitor booths. You can chat with them and all their company representatives live, and several have included their own live video chatting function as well. So make sure to take advantage of that opportunity and to thank them for their participation. Without their support, the Nebraska Oncology Society would not be able to carry out its mission of enhancing care through oncology research, education, and healthcare legislation. We also encourage you to participate in our competition. Each exhibitor booth has a unique competition code that is located somewhere inside of their virtual booths. If you're able to find 4 of these codes and email them to me before the end of the day, you will be in the running to win a $100 Amazon gift card. And with that, I want to introduce our first speaker, Dr. Mary J. Fidler. Dr. Fidler is a thoracic oncologist and associate professor in internal medicine at Rush Medical Center with an emphasis on lung cancer treatment. She has extensive clinical experience treating early and late stage lung cancer patients. Dr. Fidler is the national principal investigator for the ADAURA trial, which is studying post-operative osimertinib in resected EGFR positive lung cancer patients, and is the institutional principal investigator for several stage 3 and 4 lung cancer clinical trials. She will be discussing what should we add to epidermal growth factor receptor YKIs in newly diagnosed patients.
Why isn't it? Oh, there we go. All right, great. Sorry for the technical difficulties. Treatment with EGFR tyrosine kinase inhibitors has really revolutionized the way we treat those patients with activating EGFR mutations. And the question is how can we do better? We have some impressive outcomes with median progression-free survivals, about 18 months with some of the 3rd generation tyrosine kinase inhibitors. Some benefit if we sequence drugs and target specific resistance mutations. But how can we do better? Because even though these patients are living on average much longer than patients without EGFR driver mutations, we still know that resistance will happen, and a lot of these patients are young. And I saw on the EGFR resistors page that the city L train is by my window. I saw on the EGFR resistors page today that they lost one of their founding members who was diagnosed at age 29. So, for him, that living 6 years is, it's great for a lung cancer patient with stage 4 disease, but not great, for someone who is 29 years old. These are my disclosures. I also consult for Jazz Pharmaceuticals. So how do we improve upon frontline tyrosine kinase inhibitors? Well, there's different strategies. There can be synergy with anti-angiogenic agents. The potential additive benefit of chemotherapy may be worth it, and we'll see that. Using molecular characteristics for intensification of therapy also may be a strategy for how we can improve. So there are several preclinical studies showing a potential synergy with EGFR inhibitors and anti-angiogenic agents. And I'd like to highlight some recent publications out of Dr. Haymock's lab from MD Anderson. And it showed a few interesting things. Sorry, L train. I think more people are commuting now than before. So the first study is in cell lines with EGFR mutations had higher VEGF RNA than in cell lines who had the wild type epidermal growth factor mutation. And just to remind everyone, I guess I didn't say at the beginning, this is the most common actionable driver mutation that we have right now. We do have some other driver mutations that are coming down the pipe. As far as KRAS is a big one that we're hoping we'll have an FDA approval for at some point in the near future. But EGFR is the most common driver mutation we see in patients with never smokers. It's a little more common in the Asian descent, and there are multiple tyrosine kinase inhibitors now in development and some approved for the treatment. So just going back, so patients with the EGFR wild type had less VEGF RNA expression, and VEGF is the continuous angiogenic factor that's sort of present throughout the life cycle of the cancer cells and the tumor growth. They also saw in these cell lines that there was less VEGF secretion when these cells were treated with tyrosine kinase inhibitors. So these are the bars for osimertinib, which is our FDA-approved third line and most commonly used drug in the United States. And you can see that the VEGF levels actually went down treating with osimertinib. What I found very interesting is when the patients progressed on the patient's lung cancer progressed on osimertinib, it seemed like with what you did next, the VEGF and the EGFR receptors became delinked, meaning that it may be better to target these two pathways up front rather than treat with the tyrosine kinase inhibitor first. So these are some strategies. This was the Japanese group, Northeastern Japan group, had a randomized phase 2 trial with erlotinib plus bevacizumab versus erlotinib alone. Bevacizumab is an monoclonal antibody targeting circulating VEGF. Erlotinib is one of the earlier generation tyrosine kinase inhibitors, and patients are randomized to receive the combination therapy or erlotinib alone, and they saw a progression-free survival benefit adding the bevacizumab to erlotinib. Meanwhile, there is a phase 2 trial conducted in the United States with the same regimen that did not have a positive outcome. The Relay study was presented and published relatively recently, and this was a phase 3 randomized trial, and it included patients with EGFR activating gene mutations. The most common ones were included exon 19 deletion or L858R. Patients were not included if they had brain metastases, so that is a limitation of this trial because those patients were excluded. And the primary endpoint was progression-free survival. Patients were risk stratified based on their kind of mutation, the region, East Asia versus other, and how they were tested for the EGFR mutation. Here we see some safety events, and we see common VEGF, known VEGF related events in patients receiving the bevacizumab, but there were no unknown safeties, no surprise safety signals, and the expected EGFR related side effects were not changed. But we did see a very significant progression-free survival benefit adding the ramucirumab. So this is different than bevacizumab in the sense that ramucirumab is a monoclonal antibody targeting VEGF receptor 2. That is the receptor on the cells that is thought to do most of the angiogenic signaling and downstream activation of the hallmarks of cancer. So here we see a significant progression-free survival benefit in this large phase 3 trial, adding ramucirumab to erlotinib versus erlotinib alone. In a subgroup analysis, both exon 19 and exon 21 alterations, patients with those seem to benefit with the addition of ramucirumab. There basically appeared to be a benefit in all the different subsets when analyzed. So I want to go backwards and just remind you about the preclinical data I showed you with Dr. Haymock's lab. And so now this is a study that was very recently published, 2021 in JAMA Oncology, adding bevacizumab in patients who have received a previous tyrosine kinase inhibitor. And this was a study looking at osimertinib plus or minus bevacizumab in patients who had the acquired T790 mutation. So in patients exposed to erlotinib or gefitinib and also afatinib, the most common resistance mutation is the T790 mutation, which is seen in about 50 to 60% of patients. So when one detects that mutation, they can receive osimertinib, that's an FDA-approved indication with efficacy, with median progression-free survival is around 10 months, if I remember correctly. So this was a trial adding bevacizumab to osimertinib in this previously treated setting, and they had 87 patients registered. The response rates were higher in patients receiving the combination therapy, but the overall survival was not improved. And here we can see some information about the patients, and we do see that some patients did have a history of a anti-VEGF targeting agent in about 15% of the patients. And this study did include patients who had brain metastases. Osimertinib does have significant brain activity when given to patients with lung cancer brain metastases and EGFR. So here was the progression-free survival curve. Again, it's hard to say that there was a benefit adding the bevacizumab, but what I found interesting about this trial was that patients who had a prior receipt of VEGF therapy, those patients fared the worst, and you can see that the front orange speckled line has a pretty short progression-free survival with that combination. But even in the patients who did not have prior anti-angiogenic therapy, there wasn't a big signal adding the bevacizumab. So perhaps Dr. Haymock's signal is true that the pathways do become maybe more delinked. They also look to see if adding a bevacizumab, which has anti-angiogenic agent type toxicities, appeared if people were discontinued that agent and that affected the progression-free survival, and the discontinuation of bevacizumab did not appear to affect progression-free survival. So how do we, can we use chemotherapy as a dose intensification strategy? I had remembered, before some of the recent data was presented, the IMPRESS trial. This was a randomized trial of continuing gefitinib upon progression with the addition of cisplatin and pemetrexed. And the arm that included and kept the TKI going performed worse than the arm that had the placebo with chemotherapy. And they thought that most of the detrimental effect was seen in the patients who had that acquired T790M mutation upon progression from one of the first or second generation TKIs. In this case, everyone had received gefitinib, so with the progression on gefitinib. However, we did see some randomized frontline phase 2 data that suggested that combining everything in the frontline could be advantageous. The first study I wanted to review was the 2-to-1 randomization of gefitinib plus pemetrexed, so single agent chemotherapy versus gefitinib alone. They had 195 patients. This study was conducted in Asia, and the median amount of pemetrexed cycles was 12. And we can see that there is a numerical and statistical improvement in the progression-free survival at 15.8 months. And for those of you who don't remember offhand, the FLAURA data, that was the large phase 3 randomized trial comparing osimertinib, our third generation tyrosine kinase inhibitor, to gefitinib or erlotinib. The progression-free survival with the third generation agent was around that 16 to 17 month mark. So here we see progression-free survival numerically approaching that of single agent osimertinib with gefitinib, which is not as active as osimertinib in this patient population. There was a second study with frontline phase 2 data, and this was a slightly different design. It was concurrent gefitinib plus carboplatin pemetrexed versus an alternating sequence approach. And the arm that performed a little bit better as far as overall survival was in the concurrent arm over the sequencing approach. So based on these two trials, investigators in India launched a large phase 3 trial of gefitinib versus gefitinib plus carboplatin pemetrexed in patients with EGFR activating gene mutations. They allowed for all of the activating gene mutations that could be determined on next generation sequencing. Other important inclusion criteria, they allowed patients with performance status 2, and patients could have had brain metastases. So patients were stratified by performance status and also the type of mutation, so exon 19 versus others. And again, the randomization was chemotherapy added or gefitinib alone. And the primary endpoint of the trial was progression-free survival. So 350 patients were enrolled. 20% of them had a performance status of 2 on the ECOG scale, and close to 20% also had brain metastases. And again, gefitinib doesn't quite have as much CNS activity as some of our later generation tyrosine kinase inhibitors for this EGFR patients with EGFR. The dosing of gefitinib when chemotherapy was added was given for a longer time period, a median 327 days versus 260 days in the single agent arm. Gefitinib interruptions and dose reductions were similar whether or not chemotherapy was added. And here we can see the significant progression-free and overall survival curves, both favoring the addition of chemotherapy. We see a median overall survival in the gefitinib arm alone of about 16 months. And we see the median overall survival not reached when chemotherapy was added. For progression-free survival, again, with adding the chemotherapy brings this first generation agent up to that number that we typically see reported with osimertinib as a single agent, with the median progression-free survival around 16 months. So toxicities were higher in the combination arm, and they're clinically relevant in over half of patients who received chemotherapy in addition to gefitinib versus 25% in the gefitinib arm alone. And as far as subsequent treatment, so 44% of patients on gefitinib went on to receive subsequent chemotherapy, and 32% the chemotherapy was carboplatin and pemetrexed. So there was some crossover, but there are some patients who did not go on to get subsequent chemotherapy. And I think that's a concern that we all have as lung cancer physicians, that patients with lung cancer can progress relatively quickly and become symptomatic where they're not able to go on to receive, subsequent treatments. And that number, that 44 to 50% number, that number we see in multiple trials, including some older data from Dr. Hanna at Indiana University, where they followed patients, and there is this drop off. So I think it's a valid concern. So how can we use biomarkers of poor prognosis in patients with EGFR and non-small cell lung cancer? So there are some pre-existing genomic alterations that have clinical meaning. There's alterations in the 1-beta-catenin pathway, cell cycle alterations. You can have co-amplification of HER2 or MET, and this can be before exposure to tyrosine kinase inhibitors. And we also know that RNA sequencing may identify fusions that could be mechanisms of resistance that's missed by the DNA next generation sequencing. We routinely use a platform for determining the genomics of our patients with non-small cell lung cancer that includes DNA and RNA sequencing, because right now we can't act so much on the RNA-seq potential mechanisms of resistance, but we can act on additional driver mutations that may only be captured by also doing the RNA sequencing. So this was also a study out of Dr. Haymock's lab, and he looked at gene profiles in wild type versus EGFR mutated tumors, and the co-alterations were similar across EGFR subtype, so the exon 19 versus 21. Mutations in P53, retinoblastoma, and NKX2-1 occurred similarly in early versus late stage patients, but some mutations occurred more commonly with metastatic progression, and an example was the PIK3CA, which is important because that hopefully will be more targetable in the future. So this is an example of a patient's, for lack of a better word, mutation journey. Upon presentation, this patient had an activating mutation in EGFR, but also mutations in RB1 and P53. And the patient was treated with frontline tyrosine kinase inhibitor with gefitinib. The EGFR T790 mutation developed. As I mentioned, that's the main resistance mechanism for patients with earlier generation TKIs. The patient was then treated with paclitaxel and carboplatin, and then with osimertinib. And this patient underwent a small cell transformation and also had some other mutations noted. But what has been seen is that pre-existing mutations in retinoblastoma and P53 can increase the risk of small cell lung transformation, which is not insignificant. I've had 1 or 2 patients in my practice that have transformed. I've also had patients who, upon repeat biopsy, have squamous cell histology, and we've made treatment decisions based on that. But small cell transformation is somewhere between 5 and 10% of patients. I have an interesting patient in my practice now who presented with 2 morphologies on histology, cells with small cell and non-small cell lung cancer. So I asked the referring physician to send off the next generation sequencing, and sure enough, she had the EGFR activating mutation, received carboplatin etoposide, and went on to receive osimertinib as sort of a maintenance, and she's fortunately doing well. Another biomarker that could potentially be associated with more aggressive phenotype, tumor mutational burden. Luckily, this talk isn't about immunotherapy and tumor mutational burden, because I think that has become more and more confusing. But in EGFR, there is some data suggesting that high tumor mutational burden has less time on their tyrosine kinase inhibitors and inferior outcomes. Something a little bit more easily to measure, we have this is our study that we did in collaboration with the University of Chicago, and we looked at neutrophil lymphocyte ratio in patients with EGFR positive non-small cell lung cancer, and both at the treatment start, 6 weeks, 12 weeks, a high neutrophil lymphocyte ratio was associated with worse progression-free survival. And a multivariate analysis looking at the value at 12 weeks was actually associated with inferior overall survival, as well, suggesting this chronic inflammation is a poor marker of outcomes. But I wonder if that could be used to identify patients for potential therapy escalation. Based on some of the data presented and some of the preclinical data I didn't show, there are several rationally designed clinical trials that are accruing. We have the first clinical trial open listed, which is osimertinib plus or minus ramucirumab. There's also a phase 3 trial with osimertinib plus or minus bevacizumab. The investigators presented their phase 1 data with this strategy, and patients didn't have increased toxicity, so they're moving on to the phase 3 because it met its 1-year progression-free survival endpoint. There's also a trial with osimertinib plus or minus carboplatin pemetrexed. That's an industry-sponsored trial by AstraZeneca. There's a interesting trial looking at adding carboplatin and pemetrexed to patients with that co-mutation in P53, so potentially worse prognosis. And then an interesting design by Dr. Yu and her colleagues at Sloan Kettering is treating patients with osimertinib, and then they followed circulating tumor DNA and molecular analyses. If there's not clearance of circulating tumor DNA, then in patients who've had P53 or retinoblastoma mutations identified, they are getting cisplatin and etoposide added to their osimertinib regimen. So some really novel and interesting clinical trials designed. So in conclusion, adding VEGF2 monoclonal antibody and systemic chemotherapy improved outcomes with first-generation tyrosine kinase patients with EGFR mutated non-small cell lung cancer. Biomarkers are being identified to identify poor prognosis patients and those likely to transform into small cell lung cancer. Future directions will likely capitalize on co-targeting EGFR with other co-mutations that are seen at diagnosis. And probably most importantly, patient input on study design and outcomes is critical with strategies involving dose intensification with patients with EGFR positive lung cancer. Because right now the standard of care, for example, in the United States is to typically administer osimertinib, which has good single agent activity. Adding angiogenesis agents, adding chemotherapy is increasing toxicity and also making patients come to the clinic much more frequently. Most of my patients, when stable on their regimen, are coming once every 3 months. But certainly with the first generation agents, adding the ramucirumab or the chemotherapy really does seem to improve outcomes in those patients. So that is my last slide.
All right, do we have any questions for Dr. Fidler? And you can feel free to text or type those in the chat box, or unmute yourself and ask Dr. Fidler directly.
We can talk about other, there's so much to talk about. 2020 was a banner year for lung cancer with 8 FDA approvals, and we've already had a couple of more approvals this year. So if we can talk about perioperative, we can talk about other subjects if you don't have any questions about the EGFR.
I have a question. Can you hear me okay?
Let me turn up my, oh shoot. Okay, I turned up my volume.
Okay. My name is Sam Reno. I'm a medical oncologist in Omaha. Quick question. I have a radiation oncologist, actually, colleague of mine who got diagnosed with exon 19 deletion lung cancer, and her tumor burden was quite extensive. She was started on osimertinib and appears to be responding everywhere except for recurrent pleural effusions that, we had to manage with Loix catheter placement and things of the like. So, my question to you is, have you seen those kinds of cases where there is a response systemically in, all of her disease except for an effusion that keeps recurring that is proven malignant? And is there a benefit to adding a VEGF inhibitor?
That's it's a tough question. I think that there is data showing that a small series of patients showing that the prevalence of pleural effusions with patients with EGFR activating mutations is higher than I realized. And I have a patient now on a clinical trial with osimertinib plus ramucirumab, and she has had to have her fluid tapped multiple times, but her cancer is otherwise responding and she's feeling fine. So, whether adding VEGF right now is helpful, I think it's hard to know. Dr. Hammock's lab data would suggest that maybe it's not. Anecdotally, we were doing that all the time here, and we'd add bevacizumab. That was a little bit easier to get. Metronomic Cytoxin to try to target angiogenesis. But I think when, I was reviewing some of these patients, and when I was looking at their charts, it seemed like the cancer was kind of slowly growing all along. So I don't know if I would change course just for the pleural effusion if it can otherwise be managed. But it may be worthwhile sending off repeat circulating tumor DNA just to make sure there's not a resistance mechanism that can be targeted. We have the Orchard trial open, which is you need to have measurable disease for that trial, but depending upon the resistance mechanism, they have different arms. So arms adding RET, if there's RET mutation that can develop, or ALK mutation, chemotherapy plus immunotherapy if there's no identifiable mechanism of resistance. So I think I would probably resequence, and if she's feeling well, I'd keep her on it and kind of just keep a close eye on her with the pleural effusion.
Okay, thanks.
And Dr. Fidler, we did get two more questions from Dr. Tarantolo. The first is, what is the mechanism for transforming to small cell carcinoma, and how often do you repeat biopsies with each progression?
So the mechanism for small cell carcinoma transformation is an area of study, and Dr. Yu, who designed that clinical trial, just was awarded a grant, the first grant from the EGFR resistors to try to really answer that question. I don't know the mechanism for transforming to small cell. We know now that probably having some of these existing tumor suppressor gene mutations makes it more likely. But I don't know the mechanism. And I repeat biopsies if possible upon progression. If I can't do a biopsy, then I'll do a liquid biopsy. But I try to repeat biopsies upon progression, both for histology and to see if there's alterations, I would say. If someone has moved on from their tyrosine kinase inhibitor therapy to chemotherapy based platform and their disease is under control for a long time, then I would probably rebiopsy at that point, because there's been some studies showing how the clone with the EGFR gene mutation can kind of go up and down, and they may get more mileage with reintroducing the tyrosine kinase inhibitor after an effective therapy. Hopefully those answer. I'm sorry I don't have a good answer for your first question.
Okay, do we have more questions for Dr. Fidler? All right. Well, thank you so much, Dr. Fidler. I appreciate your time with us, and thank you for sharing your expertise.
Thanks for your attention. I'm happy to kick off the 2021 session for you guys. Our Illinois Oncology Society doesn't seem as active as yours, but I, for years, was on the board of the Chicago Medical Society and the Illinois State Medical Society. So I was excited to virtually come down.
Thank you so much. We appreciate it. All right, and with that, we'll move on. To our break for the evening. And again, just want to thank our sponsors for their support of all of our Nebraska Oncology Society activities. Without their support, we really can't do a lot of what we do, not just in terms of these meetings, but also all of our efforts in advocating for our patients. And so I really want to encourage you all to visit the exhibitors booth. Again, we do have a little competition going on. So during this time, if you are able to visit and find the competition code for 4 different booths and email those to me, I will put you in the running for a $100 gift card. And a lot of our exhibitors are on the line and ready to speak with you directly. Most of them are live. So I will, again, in case you're not using the virtual platform, put that link up there and feel free to visit with all of our exhibitors. All right, so thank you all. I hope that you had a chance to visit some of the exhibitor booths and speak with some of our representatives. And with that, we'll move on to our next speaker. So for our next segment, I want to introduce speakers from the American Lung Cancer and Screening Initiative, and that would be Dr. Chifu Jeffrey Yang and Ms. Ayushi Balan. Dr. Yang is a co-founder of the ALCSI. He is also a thoracic surgeon at Massachusetts General Hospital and an assistant professor of surgery at Harvard Medical School. He started the American Lung Cancer Screening Initiative, a 501c3 nonprofit, which has worked with communities across 21 states to highlight the importance of lung cancer screening for high-risk individuals. Ms. Balan is a lung cancer outreach volunteer coordinator and currently attends the University of California, Berkeley, and is currently pursuing dual degrees in molecular and cellular biology and business administration. She's a thoracic surgery researcher at Harvard University, where she collaborates with physicians to investigate the impact of the Affordable Care Act on lung cancer diagnosis, treatment, and survival. And with that, I'll turn it over to our next speakers.
Great, thank you so much for having us. We really appreciate the opportunity to talk about lung cancer screening, and Ayushi will get started with her presentation.
Absolutely, yeah. Thank you, Carmen. Do you mind giving me the ability to share screen? Okay, thank you so much.
Yeah.
Let me just... Okay. Let me just quickly fix that. Sorry about that. 2 monitors sometimes can be hard to handle. But okay. Are you guys seeing the presenter view or?
No, we're seeing the correct view.
Okay, great, awesome. Then let's get started. Okay, so as Carmen just introduced us, welcome. Thank you for inviting us. I'm Ayushi Balan from the American Lung Cancer Screening Initiative. Thank you for having us here today. And I'll be presenting to you about lung cancer screening. So before we get started, please feel free to ask questions in the chat and during the presentation, and also during the Q&A. Also feel free to unmute and also talk in the chat. If you are looking for more information, don't hesitate to check out our website and email us. So a brief introduction about ALCSI. The American Lung Cancer Screening Initiative is a 501c3 nonprofit that works to raise awareness for lung cancer and lung cancer screening. We are a team of over 50 passionate students and doctors located across the United States. We've worked with community organizations like the South Asian Network and American Indian Cancer Foundation, as well as city and state health departments, including the NYC and Connecticut health departments. We hope that in educating communities about lung cancer and lung cancer screening, high-risk community members will be encouraged to seek lung cancer screening. Today, we will discuss both lung cancer and lung cancer screening, addressing questions about how common lung cancer is, what is lung cancer screening, and how can someone get screened? So, just with an introduction, lung cancer is very common. It is the second most common cancer in the United States, excluding skin cancer, and it is the most fatal. This graph shows the American Cancer Society's estimates for the number of new cancer cases in the United States. This graph estimates new cancer cases in 2020 for the 4 most common cancers. As you can see here, it is estimated that 228,820 people were diagnosed with lung cancer in 2020 alone in the United States. To put this number into perspective, it is estimated that about 6% of people will develop lung cancer during their lifetime in the United States. That means that about 1 in every 15 men and 1 in every 17 women will be diagnosed with lung cancer. Not only is lung cancer very common, but it is very fatal. Lung cancer is the leading cause of cancer-related death in the US and the world. In 2020, it is estimated that lung cancer claimed the lives of 135,720 people. Looking at this graph, it shows the American Cancer Society's estimates for the number of cancer-related deaths in the United States. As you can see, lung cancer is far more fatal than breast, prostate, and colon cancer, causing more deaths than all of these 3 combined. Every year, there are about 50,000 more new cases of breast cancer, but lung cancer causes over 90,000 more deaths. In women alone every year, lung cancer causes more deaths than breast cancer, ovarian cancer, and uterine cancer combined. From this data, the question that arises is, why is lung cancer mortality so high? And the answer to that is lung cancer mortality is high because patients are typically diagnosed at a later stage. So before we dive into that, some specific statistics about lung cancer in Nebraska. Every year, 221,121 new cases of lung cancer and bronchus cancer are reported. As of November 2020, Nebraska has some of the highest lung cancer rates in the nation, along with some of the lowest survival rates. This is because cases are often diagnosed at later stages when it is less likely to be curable. One of the best ways to mitigate this is through lung cancer screening with low-dose CT scans. However, currently, only 5.2% of high-risk individuals within Nebraska have been screened. Nebraska has one of the lowest survival rates for lung cancer in the US to date, and every year, around 145,849 lung cancer patients die of lung cancer. Now, this is a graph looking at the proportion of patients with lung cancer by stage. Stage is a way for doctors to classify a cancerous tumor based on tumor size, if the cancer has spread to your lymph nodes, and if the cancer has spread to other locations in one's body. Currently, most lung cancers are diagnosed at a distant stage, when the cancer has already spread beyond the site in the lung where it originated. This graph is based off of data from 2008 to 2017, published by the National Cancer Institute. As you can see, about 21% of patients are diagnosed with a localized stage, while about 51% of patients are diagnosed with a distant stage where the cancer has already spread to other locations in the body. Why is this important? This is important because the stage that lung cancer is diagnosed at correlates directly with survival. So let's look at that. One way that doctors track the survival of patients is by looking at the 5-year survival. As you can see here on the left of the slide, the 5-year survival for lung cancer at the early stages is high, but as we progress to the right, the 5-year survival significantly drops and the disease progresses. Now, looking further at this, the graph is another way to understand the relationship between the stage at diagnosis and the 5-year survival. So as you can see here, we can compare the stage at diagnosis with 5-year survival, in which the 5-year survival for patients with localized lung cancer is 57.7%, but only 21.5% of lung cancers are diagnosed at this stage. In comparison, nearly half of lung cancers are diagnosed at a distant stage. And this is the crux of why early detection of lung cancer is so important. If we can detect the lung cancer at an early stage, the treatment options are better and the prognosis is better. With lung cancer being such a morbid disease, some might be wondering why the majority of lung cancers are diagnosed at a later stage. And because of that, we'll be looking at symptoms of lung cancer. Now, the majority of patients are diagnosed with late-stage lung cancer because they don't start feeling any of the symptoms of lung cancer until the cancer has grown and spread. Now, the most common symptoms of lung cancer include chronic cough, coughing up blood, chest pain, and shortness of breath. Additional symptoms may include hoarseness, loss of appetite, fatigue, persistent lower respiratory infections, and a new onset of wheezing. However, when people become symptomatic, the cancer has grown and spread to a point where it is much more difficult to treat and the prognosis is poor. If the diagnosis of lung cancer has to wait until the patient has symptoms, it is difficult to catch the lung cancer early. So how do we catch lung cancer early if patients are asymptomatic? One of the best ways to do this is through lung cancer screening. So lung cancer screening is done through a low-dose CT scan. If a patient is eligible for lung cancer screening, it is recommended that they get annual lung cancer scans. In the coming slides, we will discuss what lung cancer screening is, who should get screened, and how to get screened. First, an important distinction we want to make is that lung cancer screening is done using the low-dose CT and not the chest X-ray. We'll get into why we use the low-dose CT scan in a few slides, but the primary takeaway here is that a low-dose CT scan provides more detailed pictures than chest X-rays and are better at finding small abnormal areas in the lungs. The picture on the left is the picture of a chest X-ray, and the yellow arrows point to the abnormal area in the lungs, but it is unclear. On the other hand, on the right hand of the slide, the picture shows the low-dose CT scan on the chest. The red arrows point to the abnormal area in the lungs. And as you can see, the image is far more detailed than the chest X-ray and enables one to better see the abnormal area in the lung. Now, the question that researchers want to answer is, how effective is this low-dose CT scan in detecting lung cancers at an early stage? An important lung cancer screening trial called the National Lung Screening Trial, or NLST, tried to answer this question. Now, the NLST was a large national study with over 50,000 patients. The goal of the study was to determine the effectiveness of using a low-dose CT scan to detect lung cancer in patients considered high risk for lung cancer. The study included two groups, a group of patients who received annual low-dose CT scans and a group of patients who received an annual chest X-ray. By comparing the number of lung cancers caught and the stages that these cancers were caught at between these two groups, the study wanted to determine if the low-dose CT scan was better at catching more lung cancers at an early stage. And by looking at the results here, as you can see, of everyone diagnosed with lung cancer, the low-dose CT scan caught the most lung cancers at an early stage, which is shown on the right or on the left, while the X-ray diagnosed more patients at stage 4, much later and shown on the right. This has important implications for survival. Because the low-dose CT scan caught more lung cancers at an early stage, these cancers were more likely to be treatable, and the prognosis was far better. This translates to a 20% reduction in mortality for those who underwent lung cancer screening using low-dose CT compared to an X-ray. Now, a concern with any screening test is accuracy. So after this trial, a lot of people questioned essentially how good the low-dose CT scan would be at catching lung cancer. For every 100 individuals undergoing CT and lung screening, 75 will be negative. Of those 75 that are negative, 97.7 to 100% truly do not have lung cancer. This means that the test is very good at identifying people who do not have lung cancer. That is, if you do have lung cancer, the test will most likely come back positive and the test will not miss your cancer. Now, if we move our attention to the 25 individuals that are positive, now here we can see that 23 actually turn out to be negative for cancer, primarily with follow-up imaging alone, which is non-invasive. This means that even if your test result is a false positive, it's really easy to rule out cancer using that non-invasive imaging. Now, the two red individuals seen on the left that have a positive test result and truly do have lung cancer are more likely to be diagnosed at an early stage than if they were not to undergo lung cancer screening. This means that their treatment options and prognosis are far better. The results of the NLST was published in 2011, 10 years ago, and several studies have been published since then, further confirming the life-saving benefit of lung cancer screening in high-risk populations. Now, one of the most important trials after that is the Nelson trial. Now, in February of 2020, the results of the Nelson trial were published. Like the NLST, the Nelson trial had two groups. However, unlike the NLST, the Nelson trial had a group that received low-dose CT scans and a group that received no screening of any kind. A total of 13,195 men and 2,594 women between the ages of 50 and 74 were randomly assigned to undergo CT screening at T0, which is baseline, year 1, year 3, and year 5.5, or no screening. The results confirmed the life-saving benefit of lung cancer screening by low-dose CT. In the screening group, 58.6% of lung cancers were diagnosed at stage 1. In the non-screening group, only 13.5% of lung cancers were diagnosed at stage 1. Early detection translates into a reduction in mortality. In the low-dose CT group, there was a 24% reduction in lung cancer mortality in men and a 33% reduction in lung cancer mortality for women when compared to no screening. The Nelson trial also showed that with significant improvements in low-dose CT technology, the false positive rate was reduced significantly. Another way to be able to decrease the false positive rates is through LungRads. LungRads is the lung CT screening, reporting, and data system. And this is essentially a tool that standardizes lung cancer screening reporting and helps reduce confusion in lung cancer screening CT interpretations. So one of the biggest concerns, as we talked about earlier, was the rate of false positives. LungRads, through standardization, effectively reduces false positives as well after screening. So, in conclusion, lung cancer screening significantly reduces lung cancer mortality. But now the question arises, who should get screened for lung cancer? The United States Preventative Services Task Force, also known as the USPSTF, sets guidelines for who should be screened for lung cancer. Up until very recently, they recommended that people between the ages of 55 and 80 who have a 30-pack year smoking history or greater and who are a current or former smoker who quit within the past 15 years get annual low-dose CT scans. However, in the summer of 2020, the USPSTF released new lung cancer screening guidelines, and they finally updated them as of this month. Under the new guidelines, the lower age bound is lowered from 55 to 50, and the pack year smoking history is lowered from 30 pack years to 20 pack years. These new guidelines have nearly doubled the number of eligible individuals for lung cancer screening in the United States. Notably, the most apparent increases in eligibility have occurred among women and minority populations. However, while these guidelines include more high-risk individuals, they only include individuals with heavy smoking histories. There are other risk factors for lung cancer that are not accounted for in these current guidelines. Now, as a quick refresher for what a pack year is, a pack year is defined as smoking a pack of cigarettes per day for a year. So for example, if you were to smoke 1 pack a day for 30 years, that would equate to a 30-pack year smoking history. Alternatively, if you were to smoke 2 packs a day for 15 years, that would also equate to a 30-pack year smoking history. Now, the most important thing to know about a pack year smoking history is that it is a tool for physicians to figure out how to help a patient. By calculating a patient's pack year smoking history, a doctor can determine if lung cancer screening is recommended for a patient. Now, there are additional risk factors, and these include secondhand smoking, exposure to radon, exposure to asbestos, family history of lung cancer, chronic obstructive pulmonary disease or COPD, and previous radiation therapy to the lungs. It is important that we recognize these additional risk factors for lung cancer. While lung cancer does have a strong association with smoking, there are a large number of people in the United States that get lung cancer that have never smoked. Looking further into that, never smokers are defined as individuals who have smoked less than 100 cigarettes in their lifetime. Because lung cancer has such a strong association with smoking, people are often surprised to learn that lung cancer in never smokers accounts for about 10 to 20% of lung cancer diagnoses and is the 7th leading cause of cancer-related deaths in the US and in the world. More never smokers die from lung cancer each year than people die from ovarian cancer. This graph on the left shows the proportion of lung cancer cases that occur in people who have smoked in their life and people who have never smoked. It is then further broken down by whether they are a current, former, or never smoker. And as you can see, 80 to 90% of lung cancers occur in people who have smoked during their lifetime, and about 10 to 20% occur in never smokers. Interestingly, women are more likely to be never smokers when diagnosed with lung cancer. In fact, in the United States, 60 to 70% of never smokers diagnosed with lung cancer are women. Right now, if a patient has never smoked, lung cancer screening is not recommended. However, understanding lung cancer in never smokers is a current focus of research. And with the development of new screening technologies and risk models, there may be a way to identify high-risk never smokers who should also be screened for lung cancer. In summary, lung cancer is the leading cause of cancer-related death in the US. It is so deadly because most lung cancers are diagnosed at a later stage when they have spread to other locations in the body. Importantly, early detection through lung cancer screening through low-dose CT scans can reduce lung cancer mortality by up to 33%. Now, currently, however, only 5.7% of high-risk individuals are getting screened for lung cancer in the nation. To put this into perspective and show you how low that truly is, we compare the lung cancer screening rate to the screening rates for breast, cervical, and colon cancer on this graph on the slide. All 4 of these cancers have screening tests that are recommended also by the USPSTF, yet right now only 5.7% of high-risk individuals are getting screened for lung cancer. And this is extremely low compared to the screening rates for breast, cervical, and colon. The American Lung Association estimates that if we were to screen every high-risk individual recommended by the USPSTF in the US, we would save 48,000 lives. However, we are only screening 5.7%, which means that a lot of lives that could be saved are not being saved. So let's dive into why is that. Now, the first potential concern we will address is the cost of lung cancer screening. The average low-dose CT scan costs anywhere from $300 to $400, but most insurance companies, including Medicare and Medicaid, will cover the cost for eligible patients. However, there are a few exceptions. Medicare will only cover lung cancer screening until the age of 77. Not all state Medicaid plans cover lung cancer screening. And finally, patients will still pay the usual fees for provider appointments before and after their scan. So diving further into Medicare and Medicaid, unfortunately, not all state Medicaid plans cover lung cancer screening. Here's a map updated in July of last year showing which state Medicaid plans do and do not cover lung cancer screening. Blue states have state Medicaid plans that do cover lung cancer screening. Purple states, their state Medicaid plans do not cover lung cancer screening. And finally, in pink states, that particular information was not available. Nebraska is one of the states whose Medicaid fee-for-service programs do not cover lung cancer screening. But know that Medicare and a lot of private insurances within Nebraska do. Now, once you refer a patient to a screening center and they receive a low-dose CT scan, what comes next? A physician will receive the results of their patient's screening test and will then follow up with them to go over these results. As far as results go, there are 3 most likely outcomes. The first outcome is that the scans are normal. If that is the case, then the patient should get repeat scans every year. If the scans are abnormal but probably benign, then the physician should talk to the patients about next steps, which could include more scans, tests, or biopsies. And finally, if the scans are abnormal and suspicious, then the physician will most likely have their patient undergo additional testing, such as a biopsy. So, lung cancer screening saves lives. But a question you may be wondering is, can patients still get screened for lung cancer during the COVID-19 pandemic? And is it safe to do so? During the pandemic, the number of cancer screenings has decreased significantly. However, lung cancer screening won't stop because of the pandemic. If a patient is at high risk for developing lung cancer, it is important that they get their annual lung cancer screening test. Right now, most hospitals have operating lung cancer screening programs, and a patient can wear a mask during the entire lung cancer screening process. If patients follow the necessary precautions, like wearing a mask, lung cancer screening during the pandemic is safe. The pandemic should not deter physicians nor patients from getting screened for lung cancer. Additionally, while lung cancer screening has the potential to save many lives, it is important to address smoking cessation in the context of lung cancer screening. Lung cancer screening is not a substitute for smoking cessation. Likewise, smoking cessation is not a substitute for lung cancer screening. Smoking cessation is one of the best ways to prevent lung cancer, and lung cancer screening is the best way to detect lung cancer early. Using both is the best way to fight the disease. For every year after one quits smoking, one's risk for lung cancer is reduced by 8 to 17%, depending on the type of lung cancer you have. Another reason that smoking cessation is incredibly important is because it is required by Medicare and Medicaid services for lung cancer screening programs. However, we do understand that smoking cessation can be difficult, but there are a lot of resources for people trying to quit smoking. And to support your patients, you could go to the Nebraska Department of Health and Human Services website to see both web-based coaching options and a full list of Nebraska cessation programs divided up by county. If you're interested in that, let me know during the Q&A or in chat, and I can drop that link in the chat. So as this presentation comes to a close, we want to end on what we, the American Lung Cancer Screening Initiative, are doing to begin the widespread awareness, education, and advocacy efforts necessary to increase the lung cancer screening rate. Lung cancer is the deadliest cancer in the world. And while lung cancer screening can save so many lives, very few high-risk individuals are currently getting screened. We are working to address all aspects of this issue. We wrote and advocated for House and Senate resolutions expressing support for Lung Cancer Awareness Month and early detection through lung cancer screening. Last December, our Senate resolution was passed by unanimous consent. Additionally, we are working to teach communities across the country about lung cancer and lung cancer screening. Lung cancer is the deadliest cancer in the world, but by working together, we can overcome it and save millions of lives. It starts by collaborating to raise awareness and initiate lung cancer screening programs in our communities. So, we are so grateful to Carmen and the Nebraska Medical Association for helping us set up this webinar, and thank you so much for your time. We hope that you are able to leave this presentation with a better understanding of lung cancer and the lung cancer screening process. As we all know, lung cancer is a huge problem. It's common and incredibly fatal. That being said, there are tools we can use and actions we can take to reduce lung cancer mortality. And one of the best ones, and the topic of this presentation, is lung cancer screening. So ALCSI is always looking for help to raise awareness for lung cancer and lung cancer screening. If you have any questions, please feel free to ask in the following Q&A session. Additionally, if you are interested in helping raise awareness for lung cancer screening in your community, we would love to work together. You can send us an email or ask during the following Q&A. And so, as mentioned, now we'll be entering the Q&A portion. Thank you so much. Okay, I will stop screen share so you can see. Awesome. So Dr. Yang and I are here to answer any questions about what we just covered, about lung cancer and lung cancer screening in general. So please feel free to either unmute or drop questions in the chat, and we'll answer them as they come.
So what tools are you using in different communities to increase awareness?
Yeah, absolutely. Dr. Yang can definitely build on that, but predominantly because we are in a pandemic, of course, in-person activities are not really an option. What we're really working on and focusing on, starting from last summer and up until now, is being able to build webinars for different communities, whether it be for, as we said, like the South Asian Association, or with health departments for certain states. So that's really what we focused on in terms of raising awareness for different communities at the moment.
Yeah, I agree. That's a great question. The pandemic has made things more challenging. So predominantly it's through these types of events and having everybody come and listen and give us their thoughts and feedback. But it's also, once the before the pandemic and after the pandemic, we definitely hope to do much more in-person outreach, which is what we did before COVID-19. So.
Are there any other questions? I guess I had a question. I know that you've worked with on an advocacy front to create legislation at a local and state level. Can you just expand a bit more on how you managed to do that? What activities you focused on to get some of those advocacy pieces out?
Yeah, definitely. And actually we have Alex Potter-Hugh, who is also part of ALCSI, and she really helped out in terms of the Senate and House resolution. So she can talk about that. But on top of, in terms of local and community legislation, we've had a lot of proclamations all across the United States for different states been declared. That's just been through outreach. A lot of our members are from all over. So by being able to reach out to their local departments, passing proclamations about the importance of lung cancer screening or recognizing lung cancer month, awareness month, that's kind of what we've been doing as well. But yeah, Alex, take it away for that.
Yeah, thank you. We've had two different areas or three really. One has been with cities and working with cities to raise awareness. And out of us working with cities, it's really been them recognizing our work and the importance of screening that we've gotten the proclamations from. And so if you read one of our proclamations, it really highlights all of the important facts that we like to go over. And it's an excellent opportunity to raise awareness amongst your city officials. So where you guys live, I think it's really a wonderful opportunity to raise awareness. The other area we've done is with our governors. And so it's a very similar thing, but it's a way for our governors to raise awareness. And then the really wonderful opportunity we had was to work with Congressman Boyle in the House to introduce a House resolution, and then Senator Tina Smith to introduce a Senate resolution that was actually passed, marking the first time the Senate has ever recognized the importance of lung cancer screening in the history of the Senate. So it's been a really wonderful opportunity and an excellent way for us to get the word out about lung cancer and really lung cancer screening.
Carmen, that's a great question. And Alex and Ayushi, it was very great in going over what you guys, the steps you went to making that happen. I think in terms of other specifics, it's a lot of the senators and congressmen, they have legislative assistants who are passionate about certain areas of policy. And so having an opportunity to not just work with the senators and the congressmen, but also their staff was what helped us get these resolutions passed. And then I think that the other thing that was important to getting the resolutions passed was after the resolutions were introduced, we called and emailed every single congressman and senator to ask them to please support it. And so, and getting bipartisan support. So it was Senator Tina Smith who was introducing it, but she had Republican colleagues. So Senator Tina Smith is a Democrat and Marco Rubio is a Republican, and they having that the advocacy on both the Democrat and the Republican front was really important to getting all 100 senators to say yes to supporting the early detection of lung cancer.
Are there any other questions? Oh, there's one in the chat box. Beyond policy, what is the best way to reach/educate community medical centers that have high patient volumes? Has there been some headway with adding screening to clinical pathways?
Yeah, I guess like for ALCSI, in terms of our focus, we've really been working on being able to educate the high-risk individuals themselves to go and speak to their physician and get screening. Oh, thank you. But for us, at least for me specifically, I do remember, again, Dr. Yang and Alex can add some more. Over the past summer, I did get to contact some local health departments, disseminate some physician-oriented resources to be able to educate them about how they can integrate and look for high-risk individuals, and be able to recommend the correct lung cancer screening resources in that sense. But really, a lot of our focus has been on community, on individuals that are at high risk for lung cancer, but we would definitely love to expand and work on that as well. So.
Alex, do you want to,
I can add a little bit to that. In terms of educating community medical centers, one of the best things we found was to get clinicians and people actually involved in the process on a Zoom call all together and discussing lung cancer screening. So we had the opportunity to work with the New York City Health Department and to have nurses and physicians and just people working in lung cancer screening programs in New York City, all on a Zoom call where we outline lung cancer screening and why it's important and what we do, but really to have this open discussion on what people are struggling with when it comes to lung cancer screening, because most people are struggling with different things, whether it be identifying the high-risk patient or doing the shared decision-making process. And so in terms of adding screening to clinical pathways, I think that there's interest in primary care doctors to do like lung cancer screening, but everyone is struggling with different things. So doing Zoom webinars and getting information out to them is really important. And so I think one of the best things to do is to open up this discussion between physicians and just open up the conversation to understand what people are struggling with.
Yeah, I think that's great, both Ayushi and Alex. And just to add a little bit to what folks are saying, so beyond ALCSI, so beyond our organization, what folks have tried to do is engage primary care doctors, and because primary care doctors are the ones who are going to be ordering these CT scans. And sometimes it's really hard for them to have the time to, in a 15-minute visit, do all these things and ask questions about how much smoking do you do and how often do you smoke and when did you quit. And so at some centers who have better electronic medical record, people have started to try to automate that, automate some ordering systems. So it's easier for primary care doctors to click a couple of checkboxes to order the CT scans. But we've noticed just in talking to doctors and nurses and hospital administrators and also patient navigators just across the country that it's still primarily a awareness issue, like more so than anything else, than the electronic medical record or the paperwork burden, or just more so than anything else is really an awareness issue. Just it's not on people's radar screens. So now most people in the audience have probably heard about colonoscopies and for colon cancer and pap smears for cervical cancer and mammography for breast cancer. And most primary care doctors have heard about that. But just to give you an example, even when I was in medical school, wasn't really mentioned at all. And when I was in training, not mentioned it. The lung cancer screening was not mentioned at all. And so it's still something where, we really appreciate everybody in the audience today for listening and for being here, because whoever's here and can help us spread awareness, that's really the biggest thing, I think, still.
Do we have any other questions for our speakers? Well, I'll bring one more question, but more geared towards our wonderful exhibitors. As you know, industry partners are a big part of the equation. And so I was hoping I'd get some feedback from you guys as to ways in which we can work with industry to try to get the word out there for programs such as yours.
Yeah, I guess I can give some initial thoughts. webinars just like this, being able to get people who know about lung cancer screening, who are understanding of the situation within Nebraska or within the United States, and being able to speak about that, raising awareness at least within the organization first, and then being able to spread that. I think it's really great that you're recording these meetings, putting them on your website for other people to see as well. Putting this on social media, just getting the word out is really, like Dr. Yang was saying, building off of that, like the biggest thing and the best possible thing that I think any organization could do in order to engage with the community and the industry, and bring that awareness to them. But yeah, Dr. Yang, definitely take it away to add on.
I thought that was well said. I have no additional comments. I think Carmen's question was towards whoever here is from the industry. Do we have some folks in the industry in the Zoom call too?
Mm-hmm.
Yes, we do. So we do have a comment from one of our representatives. Shauna says, if you can email us flyers of future events, we can deliver them to offices once we return to live visits again. I also like the idea of putting the information out on social media, as we can share those posts within our networks.
Definitely. Wonderful. I will definitely help get that information to you. And in terms of social media, also, we have a Twitter, we have an Instagram. So definitely follow us there. And it'll be just another great way for us to be able to get that awareness out. So yeah.
Yeah, thank you, Shauna. That would be wonderful.
All right. And Nicole from Takeda is saying, thank you so much for this great presentation.
Yeah, thank you for coming and listening. Oh, sorry.
No, it's all right. Go ahead. Do we have any other questions or comments from our participants today? All right. Well, I want to thank both Ayushi and Dr. Yang and the rest of the ALCSI group. Thank you so much for visiting with us today and sharing your expertise and your project with us. It's a great venture, and I wish you a lot of success in what you're doing. And thank you for pulling the local statistics. In my previous life as a health department employee, lung cancer was definitely one of our biggest issues to try to tackle.
Thank you so much. We really appreciate the opportunity to talk with everybody and also to meet everybody. So thank you.
Thank you.
Thank you.
All right, everyone, and I'll just share one more slide. Just as a thank you for your participation today. We've reached the end of our event. And so I wanted to thank you all for your participation and hope that you've enjoyed your time with us, and especially want to thank all of our speakers for sharing their time and expertise with us. And of course, always thanking our corporate members for supporting today's programming. And with that, I would like to say tomorrow we'll announce the winner of the competition. And I hope that you can make it to our next event on May 5th when we'll talk about hematology. All right, have a great evening, everyone.
Great, thank you.
Thank you so much. Have a great day.